Assalamu alaikum. My name is Dr. Farwa. I'm PGT from Gynae and Obs department. Today we will discuss hypertensive disorders in pregnancy, their diagnosis and management. I have made these slides from NICE guidelines, and also the NICE guidelines were last updated in April 2023. The aim of this session is to classify the hypertension, how to manage different types, and what are the different prediction model, and what is placental growth factor testing. Hypertensive disorder affect 1 in 10 of the women, which means 10% of the women. One thing is common in all the types of the hypertension, which is BP. The BP must be 140/90 or above for the diagnosis. 20% hypertensive disorders are pre-existing, which means chronic, and 80% are de novo, which appears first time in pregnancy. Also, classify the hypertensive disorders into 3 groups. The pregnancy-induced hypertension term is now replaced with gestational hypertension. If there is no proteinuria, there are no severe symptoms of imminent preeclampsia or eclampsia, and hypertension resolves or normalizes before 12-week postpartum, it is classified into transient hypertension of pregnancy. While if there is proteinuria, there are severe symptoms, neurological symptoms, visual symptoms, GI symptoms, or hematological or biochemical abnormalities, and the BP resolves or normalizes before 12-week postpartum, it is classified into preeclampsia. The preeclampsia is further classified into preeclampsia without severe symptoms and preeclampsia with severe symptoms. The other group is chronic hypertension. In chronic hypertension, there is no proteinuria, there are no severe symptoms, and BP hypertension persists, that is, BP more than 140/90 persists after 12 weeks of gestation, 12 week postpartum. Now, the first type, the chronic hypertension, which appears in 20% of the women. It is diagnosed before 20 weeks of gestation, and the hypertension must be 140/90 or above on 2 occasions 4 hours apart, without proteinuria and without other hematological abnormalities. This chronic hypertension is associated with adverse maternal and fetal outcomes, which include stroke, low birth weight, and neonatal unit admission. Our aim is to maintain the BP in target range, to monitor the fetal growth, and to assess for prevention and prediction of preeclampsia and maternal complication. The chronic hypertension can be managed in OPD basis, and it should be managed by a consultant-led team. If the patient is already taking antihypertensive medication, ACE or herbs, then these medications should be stopped immediately and switched to the pregnancy-safe medications, which are labetalol, nifedipine, methyl-dopa. The first line is labetalol, second line nifedipine, and third line is methyl-dopa. If the BP of these patients is sustained remain below 110/70, then the medication should be stopped, and the target BP should be between 135/85. The previous guideline says the target BP of 150/100. If the patient was not taking any hypertensive medication, then the antihypertensive medication should be started if the BP remains above 140/90. These patients should also be offered Loprin, aspirin 75 to 150 mg once daily from 12 weeks of gestation. Lifestyle modification, which include weight management, exercise, diet, and salt restriction, should be advised. It should be remembered that the chronic hypertension in chronic hypertensive patient, we restrict salt intake, but not in other types of hypertension. In these patients, we have to ask the patient to come weekly if the BP is poorly controlled, and after every 2 to 4 weeks if the BP is well controlled. We have to offer placental growth factor testing between 20 to 36 plus 6 weeks if there is suspicion of development of preeclampsia. Placental growth factor is a protein that is produced from the placenta, and it shows the development of placenta. If there is placental insufficiency or placental dysfunction, the value of placental growth factor decreases, which will predict the preeclampsia. This is a table showing different values of placental growth factor. If it is a serum test, maternal serum test, If the placental growth factor is 100 picogram per ml or more, this means the test is negative and it is normal. There is no placental dysfunction, and there is unlikely and the liver the gestation or pregnancy is unlikely to progress to birth within 14 days of the test. But if the placental growth factor is less than 12 picogram per ml, the test is highly positive, and it means there is severe placental dysfunction and increased risk of preterm birth. We are going back to the previous slide. As we were discussing chronic hypertensive patient, their antihypertensive medication, their appointments and placental growth factor testing. Now the ultrasound. We have to carry out an ultrasound for fetal growth assessment and amniotic fluid volume assessment and umbilical artery Doppler at 28, 32 and 36 weeks of gestation. CTG should be done if clinically indicated. The clinical indications are decreased fetal movement, PV spotting, or lower abdominal pain. Timing of birth should be agreed in partnership if the gestation is more than 37 weeks and BP is maintained below 160 by 110 with or without the medication. But if the earlier delivery is required, we have to offer antenatal corticosteroids and magnesium sulfate if indicated. If the patient is before 37 weeks and there are the other maternal complication, or if she is after 37 weeks and other medical indications, then we can proceed for delivery. For postnatal care, in the women with chronic hypertension who have given the birth, we have to measure the blood pressure daily on first 2 days, once between day 3 and day 5, or clinically indicated if antihypertensive medications are changed after birth. Now the target BP should be lower than 140 by 90. In antenatal period, the target BP was 135 by 85, but now in postnatal period, the BP should be lower than 140 by 90. If the patient was on methyl dopa, aldomet, this medication should be stopped within 2 days after birth, as methyl dopa causes postpartum depression. We have to offer the review of antihypertensive medication 2 weeks after the birth with their general physician and 6 or 8 weeks after the birth with general physician for the medical review of hypertension. Now the gestational hypertension. Again, we have discussed previously that the chronic hypertension is a hypertension that was present before 20th weeks of gestation, and the gestational hypertension appears after 20 weeks of gestation. Otherwise, the BP values are same, 140 by 90 or above, on two different occasions, 4 hours apart, in the absence of proteinuria and without biochemical or hematological abnormalities. Now, in new guideline, we divide gestational hypertension into severe hypertension and hypertension, not into mild, moderate, or severe, as it was done previously. In hypertension group, the BP range is between 140 by 90 to 159 by 109. For severe hypertension, the BP must be 160 by 110 or more. Gestational hypertension, which is the other name of pregnancy-induced hypertension, is a benign condition and is not usually accompanied by fetal growth restriction. Outcome in pregnancy normally good, but approximately 25% of the pregnant women will go into preeclampsia toxemia, and if it is developed before 34 weeks of gestation, she will have poorer outcome, both maternal and fetal. The risk factors for the development of gestational hypertension. The risk factors are primary gravida, age more than 40, interpregnancy interval more than 10 years, family history of gestational hypertension or preeclampsia, multiple pregnancies, raised BMI, pre-existing vascular or kidney disease. For the management, as we have divided the gestational hypertension into hypertension group and severe hypertension according to BP values, so we will divide the management into two groups. For the first group, we have to offer the once or twice weekly OPD visits. On each visit, we have to do the BP measurement and dipstick test and blood test weekly. The blood test includes CBC to check the platelet count, RFTs and LFTs to assess the liver and the renal functions. And once the placenta growth factor testing between 20 to 36 plus 6 weeks of gestation. And ultrasound for fetal assessment after 2 or 4 weeks depending upon the growth of the baby. And CTG if clinically indicated. we have to offer the pharmacological medication if BP remains above 140/90. And the first line drug is again labetalol, then nifedipine, and third is methyldopa. For the other group, which is the severe hypertension group, we have to admit the patient and we have to check BP and other vital signs to rule out the prodromal symptoms every 15 to 30 minutes until the BP falls to 135/85. The aim of treatment is to maintain the BP at 135/85. If the BP falls to this value, then we will have to manage this patient like hypertension group. We have to offer continued, we should offer continued pharmacological treatment, daily urine dipstick tests when the patient is admitted, and weekly CBC, urinary, and LFTs measurement. Placenta growth factor testing must be done at the time of admission. For fetal assessment, we have to auscultate the fetal heart at the time of appointment. Ultrasound, if normal, then we have to repeat it every 2 weeks if the hypertension persists, and CTG if clinically indicated. For the timing of birth, the timing of birth for the gestational hypertension patient is the same. If we have to offer the birth before 37 week, we will give the DEXA cover and magnesium sulfate for neuroprotection. And if after 37 week, we have to discuss it with the mother. If no other medical conditions are there and the BP is well controlled below 160/110 with or without medication, then we will offer the planned earlier birth if there are the other medical indication. For postnatal care, the postnatal care is again same. We have to measure the blood pressure daily on first 2 days, then once between day 3 and day 5, and then the review of antihypertensive medication, the follow-up visit with the general physician after 2 weeks and 6 weeks. If patient was not on any antihypertensive medication and postnatally her BP is more than or equal to 150/100, then we have to give the medication, not on 140/80 or 150/90. BP must be 150/100 or above.